So today we are presenting two cases. So one is going to be a very short one, and one slightly long. I think it's slightly of a rarer nature. Shall we get started?
Yes, please. Very good morning to one and all present, both my virtual friends and friends here and teachers. Diwali greetings at the outset. I am Dr. Rashi Agarwal. I'll be presenting the first case for this meeting today. So going straight to the case, we had this 20-year-old Maldivian girl who was the fourth born of 5 siblings out of a non-consanguineous marriage. And she presented to us in December 2021. Rather, it was a general medicine referral for and she was admitted under them for evaluation of bilateral knee pain. And to us, she was evaluated. She was referred for evaluation of Cushingoid features. So just going to the past history briefly, she had this history of bleeding disorder for which she was anyway following up in our hospital for about 1.5 years, with multiple episodes of mucosal bleeds from all sides of her body, and even hematuria, menorrhagia, hematochezia, and she was extensively evaluated, and multidisciplinary evaluation had been done, and including genetics, and it came back as negative. However, in this admission, she was found to be Cushingoid. So to give the perspective of how Cushingoid she looked, this is the photo this is where we saw her, basically. And somewhere here, this is what, so we were intrigued as to how she looked before this presentation. So we kind of dug into her old pictures. We requested her to share some old pictures of her with us. And we kind of realized that it was a very gradual process. And over the last 4 years, this girl, who's a very young, chirpy girl, has become so frankly Cushingoid. So coming to the clinical presentation, she basically had history of weight gain of 15 kg in 7 months, and stry and joint pains, and there was history of hirsutism as well, and there was history of headache, tremors, palpitation, slightly blurring of vision, and generalized tiredness. But what was not there was proximal myopathy, any menstrual irregularity, and very categorically exogenous steroid exposure. The history was very clear from the beginning. We made all attempts to rule out any exogenous steroid exposure, but there was no history of any exogenous steroid exposure. On examination, she had vitals were stable. On general examination, she had moon facies, telangiectasia of the eyelids, some acne, and grade 3 acanthosis, and prominent stry over her abdomen, buttocks, and thighs. And hirsutism, we couldn't do the FG scoring because of her recent shaving, and she did not have any clitoromegaly. Systemic examination was butt normal. So I'm taking you into a timeline of the events that have happened, and want to discuss the same with you. So the first thing was in December 2021, when we saw her for the first time as an IP consultant general medicine, and that time her biochemistry for Cushingoid, we did 8 AM cortisol, which was 7.79 micrograms per deciliter, and an 11 PM cortisol of 4.3 micrograms per deciliter, and an 8 AM ACTH, which was 19.7 picograms per ml, and OAP very well suppressed. So there was nothing very grossly abnormal about this biochemistry. At the same time, since we wanted to take this patient on our side for further evaluation, we were perplexed at this stage, and we want to take her on our side because she appeared frankly Cushingoid. There was no doubt about it. But general medicine decided to work her up at their level, and they did a couple of imaging and things like that on their own. So they did a CT adrenal, which was reported as a normal, MRI pituitary, which was reported as normal. So she was managed for her acute problems back then, and then she got discharged. So she did come back to us in OPD. So that was about a month later in the OPD, and she came back to us in January when her 8 AM cortisol was still 7.49 micrograms per deciliter. But by this time, her 8 AM ACTH had become suppressed. It was only less than 1 picogram per ml. That is our lab assay. That is the lowest limit of detection. And at that point of time, her ONDST, which we performed, showed a rise of 70, and it was a paradoxical rise of 17.85 micrograms per deciliter from the baseline. So here we had this suspicion of a ACTH independent Cushing's. This was the first time that we suspected an ACTH independent Cushing's. And then we wanted to relook at the adrenal. Since her adrenal imaging was just 1 month back, we wanted to have a relook. I went when we discussed it with the radiologist here, we took a fresh cuts of the previous scan. It was directed again to the adrenals. And then a suspicious adrenal micronodule was recognized. And at the same time, for her neck, basically she had joint pains, and an MRI also was done previously, for which only symptomatic relief was offered to her. So when we discussed this in the background of Cushing's, it was recognized as avascular necrosis. Coming to the next thing, so this patient basically hails from Maldives. So she had logistic issues, and we wanted to get her in IP right away, but she had logistic issues, and she went back to Maldives and came back to us 2 months later, that is in March 2022. And at that point of time, we got her admitted right away. And at that point of time, her 8 AM cortisol was 7.49 again. 11 p.m. cortisol was 6.98, and 11 p.m. ACTH and 8 AM ACTH was consistently suppressed. So what we notice here is a loss of diurnal rhythm of the cortisol axis, which is quite characteristic here. At this point of time, we didn't want to have any misses, so we did our 24-hour urine cortisol also, which was double the upper range of normal limit. And we also used our facility of toxicology and got a serum and urine steroid panel for the routine steroids that we have, like hydrocortisone, dexamethasone, prednisolone, everything through thin layer chromatography, and it came back as negative. So this was during her IP. So we were kind of sure that now we have this patient who has endogenous hypercortisolism brewing, and she's cycling because we have had a period of normocortisolemia, and then she has severe pain. And she also, at that point of time, she was really writhing in pain for her with in the knee and the hips basically, and it was more of a bilateral disease. So at this point of time, we did manage her osteoporosis as well by giving her 1 dose of zolendronate. Basically, so by this time we were kind of sure that she needs to be managed quite rapidly, because she was going downhill fast. But at the same time, we did not want to make any mistakes. So we did one LDDST also at that point of time. And what we noticed is that our baseline cortisol was 5.4 at that morning. And then after 48 hours of LDDST, it was 2.87. So we did not, though we did not see complete suppression as we would love to see, but at the same time, there was no paradoxical rise also. Again, but by this time we had multiple discussions within the department with the other departments, since she had some other problems brewing, so like bleeding tendencies and all. So, but we had made up our mind and taken all precautions to basically proceed with adrenalectomy. But what surprised us is that we were constantly assessing her cortisol axis on and off. And just 3 days prior to the scheduled surgery, her 8 AM cortisol was only 1 microgram per deciliter. And 1 day prior to the surgery, it was just 0.24 microgram per deciliter. So there were 2 clear periods of normo and hypocortisolemia. What I want to emphasize here is this girl did not have any features of Carney's. Coming to the biochemical investigations, everything was normal, except, and what drew our attention and kind of guided us is DHEAS levels, which was 17.4, which were low to normal range. And that also kind of helped us decide that it is not ACTH dependent in any way, because there was to and fro discussion. Even though we had undetectable ACTH levels, we were just trying to make sure that things are going all right. So we did one DHEAS levels also. That was kind of just justifying our own diagnosis. So basically, coming to the imaging that we saw, there was in the CT abdomen, after the relook, there was a 8 by 5 millimeter hypodense nodule noted in the left adrenal gland, and right adrenal was normal. This is the said CT scan, and this is where the nodule was located. This is an oblique cut of the CT, and this is the said nodule. There was just very mild nodularity. It is not unusual to miss this actually. And FDG PET CT also we wanted to do to look for it, because the other side was normal. We wanted to make sure that the other side is also not activated or at the moment, because then that would have helped us in making a decision of bilateral adrenalectomy in the first place. But it did not show any avid uptake. So there was no FDG avid uptake anywhere. And then regarding her...
Excuse me.
Yes, sir.
Sorry to interrupt, but on that CT, can you show the other adrenal? You said one adrenal is normal. Can you show that adrenal? Is it there in that CT or not there?
We have got the CT here, ma'am, but unfortunately, sir, unfortunately, we don't have that thing.
Okay.
Sir,
Actually, we can.
Yes, sir. But actually, sir, the first instance, the CT was reported as normal. Actually. So even so, this was later on. We had a look at it, thought we could see some sort of a nodularity. So it was kind of the cursory examination, sort of inspection of the radiological films is kind of normal CT. So that is how the discharge also. It's a normal adrenal CT. That was a report given.
Right. Go ahead, please.
Yeah. Coming to the her joint pains and avascular necrosis, which was kind of established, we did her MRI of the lower limbs from hip to the ankles, but I have just put representative images here. So basically, she had extensive avascular necrosis of the distal condyles of the femur, and also there was avascular necrosis of the head of the femur. Also, even tibia was involved, though we did not have, like I have just put representative images. So these were very characteristically necrotic. So she was almost wheelchair bound actually. By surgery, she was not able to mobilize also on her own. We also did one 2D echo prior to surgery, obviously to look for the cardiac status, but also to rule out any underlying, because she was presenting like the small nodules and all. That suspicion of Carnes was always there in the back of our minds, and cyclical Cushing's. So we wanted to rule out that if there is a mass lesion like a myxoma, which was not found. Coming to the next part of the story. So basically, she got operated. Till this, we have actually already gone through. So she got operated on 12th April 2022. And post-op day 4, her cortisol was 4.49. And 2 weeks post-op, we had kind of seen a restored rhythm, at least diurnal rhythm was kind of restored. 8 a.m. cortisol was 3.69 and 11 p.m. cortisol was only 0.35 micrograms per deciliter. So, but what we obviously see that it was suppressed. So we had to discharge her on a small dose of maintenance steroids. So basically, coming to the histopathology of this specimen, again, this took us some time to get the final report. And this cortex shows nodules which are composed predominantly of zona fasciculata with internodular cortical hyperplasia. So where here we had this histopathology, we see one of the representative micronodules. This was even visible on the gross of the specimen and in radiology also. So this is what we see. It's a well-defined micronodule which is composed predominantly of zona fasciculata cells. And there is surrounding also, there is no atrophy, there is all internodular hyperplasia. And her post-operative course basically was she was euglycemic at discharge. She was not requiring any medicines for her diabetes. Though her post-operative course wasn't smooth at all, and there was sepsis and antibiotic-associated diarrhea, and her joint pains and swellings were persisting. But we decided to deal one by one since we had got the main culprit out according to us. So,
can we stop for a minute now?
Yes.
So, I think some clarification is required at this stage. Before surgery, we knew that we were dealing with an adrenal disease, and as it was mentioned in the box below, we were kind of 90% sure that we were dealing with a bilateral disease with a micronodular nature. No physical characteristics of Carnes. There was no paradoxical response. Of course, it is not a very sensitive biochemical signal. So our thoughts were in the line of, was it an isolated PPNAD or was it some sort of isolated micronodular adrenal disease? So that was sort of this thing. But, we didn't want to subject the patient directly to bilateral adrenaline because of the morbidity involved. And there were some reports suggesting that, sometimes when you take out one adrenal, the patient may remain eucortisone for a long period. So we thought we could take a chance. I'm not too sure whether that was the right decision. But at that point of time, those were the lines of our thought. So just one adrenal was removed, and we hope for the best. Any questions at this stage, sir, ma'am?
Dr. Margaret has a question.
Yes,
You said there were no physical changes to suggest Carney, but did you do an echo?
yes, the echo was done. It was normal, ma'am.
Okay, thank you.
And that string of beads and the usual classical appearance was not there, but of course that need not be there always in Carney. So the Carney, the isolated PPND was always in our mind, but then there were no Carney features. So shall we proceed?
Could you tie up that bleeding diathesis in any way? Because it's actually opposite of what we would expect in Cushing.
Yes, ma'am. So actually, this was briefly Rashi had presented. We had long discussions with our hematology colleagues. So after the patient landed with us, like what we observed was she just had some episodes of nasal bleeds. And there was a thought line of the thing that it was probably a vascular stuff. In one of the someone had done scopy of the bladder, and they had found some telangiectasia. But so there was this mild suspicion of osteolar Rendu-Weber, but would never be proven, and those kind of gross telangiectasia was never found. And of course, our hematology colleagues were also flummoxed. So we had made elaborate preparations for the post-op state, all sorts of cryoprecipitate, factor 7, everything was kept ready, but then nothing happened. So it was largely uneventful. The operation, no bleeds or anything of that sort. So, but we couldn't solve that, and we were thinking that probably there was some biochemical association between these two conditions. But yeah, I will wait for your opinion on that, sir. So we couldn't solve that issue at all. Our hematology colleagues are also very good, but totally from us.
Praveen,
Yes, ma'am.
how do you explain the low cortisol? One can explain that you have times of eucortisolemia, and then you have subtly elevated cortisol. But how do you explain that the cortisol was low in that last set of investigation?
Yes, sir. So she was like cycling rapidly. So that is explanation. So this the red bands, we are kind of they represent times of eucortisolemia or even hypocortisolemia. So Rashi had one slide in which she mentioned that prior to surgery, we had just assessed the cortisol again. And then we saw that that is again because of our initial experience with medicine. The biochemistry was totally negative for this thing. So we were suspecting a cycling. So even prior to surgery, we just checked the cortisol and we found that it was low. There was a value less than 1 microgram per deciliter 8 AM. And in fact, during surgery, we just gave a couple of, obviously, that is unilateral this thing, but we gave a bit of a higher dose of cortisol, thinking that she's right now in a hypocortisolemic state. So cycling is the only probable explanation, sir, and that is probably well known with Carney. I am not too sure about IMAD. It's also described, but less literature regarding that. So that is one of the discussion points. So how we can miss these things if we do it in the wrong time.
So I think what Ish meant is that during the time, the cycling, the period when there is no Cushing, because of the previous suppression, it can actually be low and not just normal. That's what he was mentioning. You know?
I was just asking, what is your explanation? They are cycling, correct? But normally cycles are that you have normal cortisol and elevated at different times. This patient at this point in time had undetectable ACTH and very low cortisol.
Right.
So, but you're saying that you can have it in this thing, so I'll take your word for it. I also had one patient, not Kani's, but another, cycled almost every day. It was not even cycling, it was changing every day.
So
Yeah. You can go ahead, I think you're interrupting.
yes, sir. That was kind of a surprise to us also. But I think literature says cycling duration is 2 days to some few months. So it can be as rapid. So I must be frank that it's a learning thing for me also. Definitely, sir. I never knew they could cycle this fast, but this was kind of very fast. Can we go ahead, sir?
Yeah, please go ahead. Please go ahead.
Yeah. So we had this patient who was operated on the left side, and she was following up with us. And thing is that 6 weeks post-op, I'm just directly going to the 6 weeks post-op, she started developing worsening glycemic status again and worsening of her joint pains. Her joint pains was slightly better post-surgery, but they kind of worsened, and there was worsening of the general condition, and we kind of knew that our enemy is back. And at that point of time, we saw that ATM cortisol was 24 micrograms per deciliter, and an ONDST, which was characteristically unsuppressed, which was 16 micrograms per deciliter. And this time our decision making was relatively simple. We knew that we had to get the adrenal out, and that's what we did on 6th June 2022. So coming to the histopathology of the other adrenal, again, so we saw was basically hyperplasia of both zona fasciculata and zona reticularis with developing micronodules. If we compare it from the other side, there is no well-defined capsule around this area, but what we see are some hyperplastic cells which are organized in a nodular pattern. Query pseudolobulations is what a pathologist help us with. And what we also saw was medullary hyperplasia. Focally, there was medullary hyperplasia also. The only possible explanation is probably cortisol-induced upregulation of the PNMT enzyme, basically. So that's what was the histopathology was. And what I want to mention is there was no PP, and it means there was no pigmentation that was noted. So at the end of all this, basically, she was discharged on post-op day 8 with maintenance dose of steroids, and she was now adrenal insufficient. And we also gave her anti-osteoporosis measures like Terifrac, parathormone, and calcitonin for her joint pains, calcium and vitamin D supplements. Also, we gave her some analgesia and DVT prophylaxis and multivitamins. And for us, her last OPD visit was almost 3 weeks after surgery, and she had persistent of joint pains and mild hyperglycemia requiring a single oral anti-diabetic agent. But other than that, she was slightly better. We obviously knew that there is something coming from the genetics, so we did a whole exome sequencing again, this time looking at specific genes, that is myosin. We tried it. So Praveen sir did an extensive literature research for us, and he has helped us look at these genes very characteristically. So we did look at genes which are already well described for micronodular hyperplasia, but we also looked at isolated genes like myosin heavy chain 8, KCNJ5, and other genes which are also implicated in macronodular hyperplasia. But everything came back as negative. But at the same time, we were not surprised with this because it is very difficult to detect the genetic mutation in isolated micronodular adrenal disease, which I'm going to discuss further. So by end of all this, our diagnosis was an isolated micronodular adrenal disease. And the pictures that we kind of see are, it's a bilateral disease. There are presence of micronodules. There are no features of PPNAD. And at this point of time, genetics was negative.
So I must add that genetics negative means, it just means that right now the genetics is negative. We are aware of the fact that we might have missed some copy number variants and all those stuff, but the commercial labs are not able to take care of that. So we will have to go ahead and contact someone who is really interested in this in NIH and send the samples over for further CNV and embryonic analysis. So right now the genetics seems to be negative. So any please, so any comments at this stage, sir, ma'am?
No, I just I haven't read this for a long time, but the internodular tissue, which you said was hyperplastic,
Yes,
is
sir.
that characteristic of micronodular hyperplasia?
Yes, sir. Yes, sir. So there is a 2022 revised adrenal cortical this thing, nodular disease classification by the WHO. So that clearly mentions these aspects. So internodular atrophy is seen in PPNAD and hyperplasia is seen in IMAD. And then they have taken away the terminology of hyperplasia, and that is used only for the ACTH-induced proliferation. So it's all nodular disease, not hyperplasia anymore, at least according to pathology.
Brief.
So shall we proceed, sir?
Yeah,
You said that you can have hyperplasia. Is that what you said?
That is characteristic of IMAD. That is one thing which, apart from the pigment, the thing which distinguishes IMAD from PPNAD, even the isolated one, is the internodular hyperplasia, which is not seen in PPNAD. It's seen only in IMAD.
So that, but she said that there was hyperplasia.
Yes.
In the first slide.
The IMAD he's saying.
Oh, IMAD.
This isolated adrenal nodular disease. You can have hyperplasia and PPNAD you don't.
Okay. All right. Okay, got it. Thank you. Go ahead.
Yeah. So a brief thing that we want to tell is that this was our international patient. So she remained, she went home in the first week of July, and then we stayed in touch virtually only. But unfortunately, we have lost her 2 weeks back actually. She succumbed to probably urosepsis, and she was from a very poor financial background. Here, all the management was done through their national insurance, but they had a lot of social and financial issues. And despite our best efforts, we could not pull her out of that, and that kind of breaks her heart. But at the same time, she's given us a lot of lessons. Yeah. So coming to a brief literature review of this condition, there are only two things that I want to highlight, though there is n number of things that we can discuss, but the two things that distinguish her from other patients of Cushing's are her cyclical nature and the presence of an isolated micronodular adrenal disease, both of which are not very common. That is not something that we see routinely. So that are the two aspects that I'm going to discuss. So basically, cyclic Cushing syndrome are this, as we've already known, transient hypercortisolemia shifting into periods of normo and hypocortisolemia. And they may arise from hormonal activity of a corticotropinoma, which is most well described, and then followed by ectopic ACTH release or an ACTH independent cause. But this is much less common. That is about only 10 to 11% of cyclic Cushing's, or 10 to 12% of cyclic Cushing's will have ACTH independent causes. I have included two studies from European Journal of Endocrinology, one describing cyclical Cushing's in 10 children and adolescents aged 1 to 17 years. And here, if we can see, three of these children basically had bilateral PPNAD. IMAD has not been described. Two had ectopic Cushing's arising from a carcinoid tumor from RCC and a thymus, and two had Cushing's disease. But what is more well known is obviously Cushing disease, cyclical Cushing's and Cushing's disease. And here we can see that older patients, longer follow-up of these patients and female gender, and no histological identification of the adenoma are more characteristics of these patients in Cushing disease, cyclical Cushing's. So both these studies were published in European Journal of Endocrinology. Now coming to diagnosis of cyclical Cushing's, we need at least 3 periods of confirmed hypercortisolemia interspersed by 2 periods. We reach quite near to this definition actually. And the duration of phases can range from 12 hours to 86 days. And actually there is literature which says obviously that it can range to up to years also. In 5 years, we can have just 2 periods of hypocortisolemia, and in between there can be hypercortisolemia. So at what point in time we catch the patient is our destiny basically, and how we kind of go ahead of it. So the pathophysiology is, again, since it is more common in Cushing's disease, the pathophysiology that is there is more of Cushing's disease related thing, that hypothalamic dysfunction, which can produce different degrees of cortical cell response to the neurotransmitters, or a spontaneous bleeding in the pituitary tumor followed by disrupted hormone synthesis, or a persistent tumor response to hypothalamus pituitary adrenal regulatory mechanisms, none of which can explain the cyclicity in our patient, but this is what is described in literature. So coming to how would we go about diagnosing a patient with cyclical Cushing's, we will obviously, if there is a clinical suspicion and we have excluded the exogenous cause, we'll do the first line test, which we already know of, the urine free cortisol, ONDST, and the late night salivatory cortisol. So we might have to do it for more than one occasions. If they come negative, we go ahead and do the second line test, that is late night serum cortisol, 2-day LDDST plus a CRH test, and repeat first line investigations. I must admit that it is not necessary that all of these investigations are available in a given laboratory, and so we have to modify this. There is no hard and fast rule. Like for us, serum cortisol is more readily available, so we like to see 11 p.m. cortisol on a routine basis in such patients. And then we have to repeat the testing. Suppose all of this comes negative and we are not getting any answers, we might have to repeat the testing during the periods of worsening. So even we know that our patient also, whenever she had biochemical evidence of Cushing's, she was clinically also worse. Though she had Cushing's appearance throughout, but her clinical symptoms worsened during her features of biochemical worsening. So that is the time we should do the testing. And sometimes in Cushing's disease and all, we might have to do a vasopressin stimulated testing as well. And a scalp-hair cortisol also has been mentioned. If you get a positive result, we have to proceed with radiological investigations and then diagnose it accordingly. So what are the differentials of the cyclical Cushing syndrome? It is exogenous steroid use, mild autonomous hypercortisolemia, which is subclinical Cushing syndrome, which is seen in these hyperplastic and nodular conditions, non-neoplastic hypercortisolemia, which is like the pseudo-Cushing state that you see in alcoholism, diabetes, obesity, psychiatric disorders, use of xenobiotics, glucocorticoid resistance syndromes, and a factitious disorder of Munchausen syndrome, either by proxy or on their own. So Cushing syndrome, now coming to the second aspect of this discussion, that is the bilateral adrenal cortical disease. So 20% of the Cushing syndrome are adrenal in origin. Majority of them are due to an adenoma. 10% are due to primary adrenal hyperplasia or bilateral adrenocortical disease. And the New World Health Organization classification has refined these cortical nodular disease, and they no longer endorse the use of nodular adrenal cortical hyperplasia for incidentally discovered sporadic non-functional adrenal cortical nodules. So these sporadic ones are no more referred as nodular adrenal cortical hyperplasia. So coming to this classification, this is basically divides adrenal nodular disease into three aspects. One is the sporadic nodular adrenocortical disease, which is a non-functional nodule, which is maybe a solitary or a multifocal nodule, small nodule less than 1 centimeter, and it mimics an adenoma, which is just small in size, and it can occur in all age groups. On the other hand, we have bilateral macronodular adrenal hyperplasia or adrenocortical disease, which is associated with endogenous Cushing syndrome. There are multiple nodules, like more than 1 centimeter. It is seen in adults. And the common mutations that are associated with this are ARMC5, MEN1, fumarate hydratase, and APC gene mutations. But our topic of interest today is bilateral micronodular adrenocortical disease, which is seen in which again presents with endogenous Cushing syndrome with small nodules, less than 1 centimeter nodules, seen more in younger population. It is having a bilateral involvement, and there is a pathogenic germline variant activating the protein kinase A pathway. It can either be an isolated micronodular adrenocortical disease or primary pigmented nodular adrenocortical disease. I will be discussing this in the next slide. So this is a normal histology of the adrenal cortex, and we can see that there are some small, in sporadic nodular adrenocortical disease, there are these small micronodules which are non-functional in nature. Then in PPND, there are multiple of these nodules, very characteristic, and they are lipofuscin stained, so that's why they appear pigmented. And then there are macronodular hyperplasia, that is your bilateral macronodular adrenal disease. Coming to bilateral micronodular disease, which is the topic of interest today, is it can present in three ways: either as a part of Carney's complex, which is seen in children, young adults, middle adults, and there is hyperplasia and internodular atrophy and mainly nodular pigment, and it can present in autosomal dominant fashion, and the genes that are implicated are protein kinase A, regulatory 1 alpha subunit, phosphodiesterase 8B, and another locus. So that is 2p16 locus. In isolated PPNAD, children and young adults are involved. Mostly they present with isolated PPNAD, and again there is hyperplasia, that is of the nodule, but internodular atrophy and nodular pigment, and it can present as an isolated, not as part of, they don't have any features of Carnes, but when you take the adrenals out, they are pigmented. So the genes implicated here are also similar in the same pathway, with an addition of phosphodiesterase 11A mutation and protein kinase A catalytic alpha subunit. Coming to IMAD, it again presents in children and young adults, and there are microadenomatous with nature, with hyperplasia, with surrounding zona fasciculata, hyperplasia of the surrounding zona fasciculata, and limited or absent pigment. So this is what it internodular nodules will, between them there will be hyperplasia basically in IMAD, and occasionally it is part of other developmental defects also. And the genes that are implicated here are phosphodiesterase 11A, protein kinase A catalytic alpha subunit, and some other mutations, and 2p16 and 5q mutations. I'll be going through it a little more in detail briefly. So coming to the pathophysiology, the pathways that are there, basically we know that normal adrenocortical cell ACTH activates the melanocortin 2 receptor, and it kind of activates the G alpha subunit of the G protein. And this activation leads to activation of adenylate cyclase, which converts ATP to CAMP, and the phosphodiesterase enzyme basically inhibits this, inactivates the CAMP formation. And then the CAMP kind of binds to the regulatory subunits, and it leads to release of catalytic subunits. This is all that we can see in this diagram basically. And the catalytic subunits phosphorylate the targets, including the catalytic release response binding elements, which activates genes involved in the steroidogenesis pathway. ARMC5 blocks the cycle in the G1 phase and induces apoptosis, and ARMC5 is degraded by Qlin3. In PPNAD and IMAD, the protein kinase A pathway is inactivated by mutations in the regulatory, that is in this regulatory 1 alpha subunit of protein kinase A enzyme, and these mutations in phosphodiesterase, then there could be mutations in the phosphodiesterase enzyme. So basically, anything that upregulates this pathway is going to give rise to micronodular hyperplasia. And so the phosphodiesterase enzyme, also inhibition of phosphodiesterase enzyme will again produce increased CAMP, and that will again downstreamly increase the production of steroids. And then there could be duplication of the catalytic subunits here, C alpha subunits, that has also been described. So PPNAD is the most common endocrine manifestation of Carnes and can manifest as isolated disease, but 90% of the times other manifestations of Carnes complex are present. Coming to the diagnosis of this, it is always challenging due to an atypical presentation, and cyclical Cushing's is very well described. But the paradoxical rise of urine-free cortisol or 17-hydroxysteroids following a high-dose dexamethasone suppression test is one of the characteristic features of this disease. Again, well described in PPNAD. 50% rise over baseline of urine-free cortisol on day 6 of the high-dose dexamethasone suppression test also kind of tells us that it is something to do with PPNAD. Coming to the imaging, the affected gland can be normal or slightly enlarged. The weight can be 4 to 17 grams, and 1 out of 3 patients can have a normal appearing CT actually. Coming to the last 2 slides of this presentation, genetics of PPNAD, there are 2 loci that have been involved. That is the Carnes complex 1 locus and Carnes complex 2 basically. So 1 locus, that is the 17q22 to 24 locus, basically encodes for the regulatory subunit alpha protein kinase. This is the most common. PRKAR1A is the most common mutation that you find in PPNAD, and it is present in 80% of the Cushing syndrome, and 70% of this is familial, and rest are de novo. And most germline mutations are noted in the exons on 2, 3, 5, 7, 8, but 20% are located in introns and affected splicing areas also. And then there is another locus, that is the CNC2, that is the 2p16 locus, but the function is still now unknown. Coming to IMAD genetics, Phosphodiesterase 11A mutations have been known, that is in chromosome 2q31. It encodes a dual specificity phosphodiesterase enzyme that degrades both CAMP and CGMP. So as we can remember from the previous slides, anything that does not degrade CAMP will kind of upregulate the steroidogenesis pathway. So there are 4 different transcripts of that. Phosphodiesterase 11A4 has been identified in adrenal tissues. So this is the mutation, and 5 different mutations of phosphodiesterase 11A have been identified so far. 3 of which cause premature stop codon generation, and 2 were single base mutations. Coming to phosphodiesterase 8B mutation, this is the second phosphodiesterase enzyme needed in degradation of CAMP, and it is the second most favored locus. It is located in 5q13 basically chromosome. And then there's the third enzyme, that is the protein kinase A, alpha catalytic subunit. It's basically a copy number gain. So if the catalytic subunits are increased in number, they will overwhelm the regulatory subunits, and again it can present as micronodular adrenal disease. So these are the main genes that have been studied by and been found. These mutations have been found by the NIH group, but it does not mean there are isolated case reports of some other genetic mutations, like I have mentioned previously, myosin heavy chain 8 and all, which have been described in isolated micronodular adrenal disease. Coming to the treatment, there is no consistent management because clearly it's a very rare disease, so it's only coming from experiences. Bilateral adrenalectomy was always a treatment of choice. But what Praveen sir was mentioning earlier is that unilateral adrenalectomy has been proposed in both macronodular and PPNAD, offering interesting results, especially in patients with macronodular adrenal disease. And sometimes it has been seen that the patients who undergo unilateral adrenalectomy, sometimes they will do well for several years, and then they will have a very low, slow and progression of the disease, and the cortisol levels will remain down. So this is well studied in macronodular adrenal hyperplasia, but there are some reports coming in micronodular disease as well. Advances in understanding molecular pathways may help in developing medical treatment directed to the gene defects. Thank you, sir and ma'am.
So, sir and ma'am, are there any questions or comments at this stage?
No, I think that was a very nice review of the literature, and certainly learned a few new things about, and different from the other patients that we have seen of macronodular hyperplasia. And I don't know if Margaret, do you have any questions?
No, I don't think I have anything to add. It was a wonderful presentation. Thank you.
Can I just ask if there are all germline mutations, or can you have only somatic mutations also?
No, sir.
If you don't find a germline mutation, can you have somatic mutation? You have to look for that?
Yes. So, sir, actually, all what Rashi mentioned is solely about this germline mutations. Of course, these somatic mutations are mentioned in another way. So, you know, but we are talking about a bilateral disease here. So, 90% of the time it's going to be germline. Yes, somatic mutations are described, sir. And all those other channels are slowly coming up. So, KCNJ and all those stuff, but not much of literature regarding that. As you know, most of the literature is on this hyperaldosteronism. But again, there is something coming up. So we have not put any slides on the somatic mutations here.
All right.
Supposed to look for that, sir. Actually, clinically, I don't think it's indicated to look for that. But I think it's changing times. So probably things will change the next few years.
Yes.
Wonderful.
Thank you, ma'am.
We can go to the next one.
Yes, ma'am. So it's a kind of a short one, and we would love to have insights from Vijayalakshmi ma'am and Dr. Margaret here in this case.
And Dr. Gabby.
Yes.
She's today's expert on DSD conditions or
Oh, welcome, ma'am. So we'd love to hear from you as well.
Good morning, members of the faculty and my colleagues. The second case for the day is a very short presentation. So with your permission, I'll move on to the second case. The patient who came to us was a 31-year-old female. She's an engineer by profession. She came to the endocrinology OPD with history of primary amenorrhea. A little bit of background is that the patient was the first child in a non-consanguineous marriage. Her antenatal history was uneventful. There was no history of any prolonged NICU stay, no history of any maternal virilization or salt wasting crisis or failure to thrive. History of, they had noticed some bilateral abdominal swellings on day 4 after birth. They were reassured. The milestones, the developmental milestones of this lady was normal. She developed, breast development was at the age of 14 years. Axillary hair was developed around the same time, but the quantity was very scanty, and there was scanty pubic hair as well. The patient, however, came with history of primary amenorrhea, but there has not been any thyroid issues, no history of any galactorrhea or cyclical pain, no surgeries were done at a young age, no worsening of this herniation. She had no history of any anosmia. Personal history was that this patient was married since the last 3 years, but she never conceived. And family history, the younger sister has a similar history. She's married with no children. An ultrasound, when she came to us, she had had some basic investigations with her. The ultrasound, which was done outside, did not show any adnexal masses, but no ovaries or uterus were seen. The bilateral iliac region showed ovoid hypoechoic areas of 3 × 1 centimeter on the right side and 3 × 1 centimeter on the left side. This was suggestive of testis. Juxtatesticular Mullerian ductus measuring 13 × 8 millimeters were seen on the right side and about 19 × 12 millimeters on the left side when noted. She had done a karyotyping from outside in May 2017, which showed 46 XY karyotype, all 20 cells were karyotyped. On examination here, her height was recorded as 171 centimeter, weight of 61 kg, blood pressure of 120/70. Tanner staging, breast was B4, axillary hair was absent, pubic hair was scanty, clitomegaly was absent, there is no genital ambiguity, no palpable masses per abdomen was found, and there were 2 separate openings, one for the vagina, the other for the urethra. No syndromic facies and no Turner stigmata could be found. So we made a clinical diagnosis based on all these findings and history as a complete androgen insensitivity syndrome. Moving on to the investigations that we had done from here. The baseline investigations, blood investigations showed that estradiol level of 74, an LH level of 33 international units, FSH of 18, and a total testosterone of 3.25 nanomoles per, which was on the higher, which was higher than normal. Ultrasound showed sonologically no non-visualized uterus and ovaries. An oval hypoechoic structure in the right iliac fossa could be found in ultrasound, which was suspected to be a gonad. We moved on to the MRI, abdomen and pelvis. The MRI basically showed absence or agenesis of the Mullerian structures with presence of a short distal ending vagina. Bilateral solid cystic structures were found in the left adnexa and the right iliac fossa, which are likely to be testis with adjoining Mullerian ductus. And the staining of abdomen showed that bilateral kidneys are normal with no other contributory findings in this case. The MRI showed the right testis and the left testis, which confirmed our ultrasound findings. A whole exome sequencing was done for this patient, which showed that.
Ma'am, can you hear us now?
Yes, now we can.
Yes, ma'am. So there was a small hitch here. Yeah. Okay. Yes, ma'am.
Yeah, I think we would like to allow Malini. Is her name Malini?
Yes, ma'am.
Yeah, please go ahead.
So this, as I was saying, the whole exome sequencing showed a particular mutation in the 898th position in the C domain, where methionine was replaced for valine. This is considered as a pathogenic mutation in the database, and that the inheritance was X-linked recessive. So when it came to the decision to make treatment plan for the patient, we had a discussion with the patient and the husband, and we had advised a gonadal preservation protocol as is what is being followed currently, but they decided to undergo bilateral gonadectomy due to personal reasons. So surgery was done, a diagnostic laparoscopy with bilateral laparoscopic orchidectomy on 28th of June in 2022. The laparoscopic findings were that there were bilateral testes seen near the deep ring with small deep ring and rudimentary vas deferens, and bilateral gonadectomy was done and the testis was removed. The post-operative period of this patient was uneventful. Just a word about the histopathology. The bilateral testes showed bilateral epididymal cysts. These cysts were lined with a single layer of pseudostratified ciliated columnar epithelium. The bilateral testes predominantly showed a Sertoli cell predominance, as is seen in the picture. Germ cells were very less in number. It was predominantly Sertoli cells. And the right testis basically showed the Sertoli cells being arranged in a tight glandular pattern, suggestive of Sertoli cell adenoma. Following the surgery, about 2 weeks later, patient had come to us. The investigations on follow-up showed the estradiol level had dropped to 5. LH and FSH had increased 55 and 95 respectively, and testosterone levels had also decreased post-surgery. The patient was given the option to start estradiol valrate after 3 months post-operatively and to follow up after 3 months. So this was the gist of the case presentation. Just a word about androgen receptor mutations.
Mutations, we can leave it alone because there's no, yeah. So,
yes, I just wanted to point out that the current mutation in the patient is recognized in the androgen receptor gene mutation database. This is the mutation. We have just a word about the correlation between genotype and phenotype in AIS. In the AR mutation database, there are some AR allelic variants that can cause different phenotypes. So as such, there are hard and fast rule as to a single mutation should cause only one particular phenotype. The explanation for this is not completely understood, but it's hypothesized that AR co-regulators, activators, and repressors may be implicated in this phenomenon. As you can see from the table that we've taken from a presentation, our particular mutation that which I have highlighted over here can present as either CAIS or PAIS, and in our case, it has presented as a complete androgen insensitivity syndrome. Just a word about oncological risk, because we are on the subject here. So according to the latest guidelines, germ cell neoplasia in situ, in complete androgen sensitivity, the prevalence is about 9.8%, while in partial, it is 6.6%. So PAIS individuals do not seem to be at a higher risk as compared to women who have CAIS, in contrast to what was previously thought before. And there are some factors which will contribute to the low risk, which are the relatively normal testicular architecture, apoptotic removal of abnormal germ cells in childhood, and the lack of paracrine androgen signaling, which usually converts the in situ lesions into a full-blown germ cell tumor. Just a word about some future biomarkers which can be used for as a marker for development of germ cell tumor in this particular population. MicroRNAs, especially the microRNA 3713 and the MIR 302-367 clusters, they are overexpressed in germ cell tumors, in all germ cell tumors except in teratomas, and this is irrespective of the tumor site. And targeted serum detection of these particular microRNAs can be used as diagnostic tool in the future. There are other diagnostic markers like the OCT34, this marker for delayed maturation of germ cells that can also be used as a histological marker for malignant transformation. And the KIT-LG, a polymorphic P53 response element within the promoter region, can again be used as a marker. And all of this is under experimental sessions right now. Just a word about common mutations in CAIS associated with pre-malignant and malignant changes. As such, we don't have a lot of data regarding the direct correlation between certain mutations and the development of pre-malignant or malignant lesions. This is so far what we have come across. So this particular mutation, I just want to point out that the the missense mutation 832, the stop codon, that particular mutation is associated with malignant sex-cord stromal tumor. So far, this is the only mutation which we have come across, which has a definite malignant transformation risk. like we already explained, the early gonadectomy protocol, which was what we were which we were using in the previous years, has a lot of fallacies. The fallacies being that before this AR sequencing was done, most of the DSD, 46 DSD conditions, 46XY DSD conditions were clubbed together. This included the gonadal dysgenesis category as well. So there was a false elevation in the gonadal malignancy risk. Now that the AR sequencing is done commonly and exome sequencing is done almost in all centers, good centers at least, this particular malignancy risk has come down specifically. Hence, we are not using this gonadectomy protocol for all patients. No specific markers were available before that would suggest that the patient is developing a germ cell tumor. But now that I've already mentioned some new biomarkers which could be used, that this particular fallacy, the lacunae, can also be terminated. A third limitation, which is still unclear, is the exact age at which malignant changes can occur, that we are still in the dark regarding data for that. Now, the patients are now given a choice to go ahead with preservation or to go ahead with gonadectomy. That depends on CAIS, that depends on certain conditions, certain criteria. So if the CAS is diagnosed in childhood and if the gonadal location is abdominal, usually no action is required. If it is inguinal, you don't really do much intervention unless there is some indication like a mechanical hindrance, and we just preserve the gonad as such, because we have to give the time to for the child to go through a normal puberty. While if the same is diagnosed in the adulthood, we have to explain the pros and cons of gonadectomy to the patient. The pros being that since we don't have any particular reliable non-invasive surveillance tool to detect the NIS, and the NIS risk, like I said, is around 10 to 15%, there's a chance that they can develop a malignancy in future. The cons being that the risk of progression is quite low, and there is definitely going to be a lifelong dependence in HRT. So if the patient chooses gonadectomy, then we go ahead with it, like how we did with this particular patient. But if the patient chooses surveillance, then there are surveillance techniques for annual follow-up for this patient. So the annual follow-up is usually done with ultrasound, which is widely used for screening and detection. If they have intra-abdominal gonads, then we suggest an annual transabdominal ultrasound. If it's not well visualized, then we usually go for a contrast-enhanced MRI as a part of screening and surveillance imaging. And recommended is MRI every 5 years until the transabdominal ultrasound becomes more reliable. We can also use a diagnostic laparoscopy, but it's not done as a routine. It is recommended as a baseline in certain conditions, especially when the imaging is equivocal, when things do not go as planned. And if the gonads, during laparoscopy, if the gonads are indicative of malignancy in their appearance, then we definitely will take a biopsy. And if it's grossly abnormal, then we take the gonads out with consent, of course. And gonadal biopsy, however, there have been no discussions in the literature regarding the utility of any gonadal biopsy as a routine for surveillance or screening. So annual follow-up is done. The baseline workup is normal. We keep monitoring the patient annually. And if there is some imaging indicative of disease, we follow up with an MRI, which is more specific. And if there are abnormal MRI findings, then we go ahead with laparoscopy. And if at any point, if the gonads appear abnormal intraoperatively, then either we do a biopsy for a future reference, or we take the gonads out depending upon the condition on table.